Today's module is on ulnar neuropathy at the elbow, commonly called Cubital Tunnel Syndrome. This is a condition where so-called funny bone, the part of the elbow where the ulnar nerve goes through, can get irritated and actually injured to the extent that there is dysfunction of the ulnar nerve. This can be fairly straightforward to diagnose, but to complete the diagnosis, one often needs more specialized studies, such as nerve conduction studies. It's important to make an early diagnosis so patients can get the prompt treatment they need and, in severe cases, get surgical consultation, assuming nothing else has helped the patient. We'll talk about that more in the physical exam and history portion of this module. The cubital tunnel is a tunnel on the inside of the elbow between the medial epicondyle and what's called the olecranon, or the bony part of the elbow. So it's a tunnel where the ulnar nerve passes through. And the ulnar nerve can get damaged in this area and cause a compression. Much less common than, for example, carpal tunnel syndrome. Often it is traumatic, at least for the younger patient, but for some older patients, say people who've worked in construction for years, they will get this gradually with time, more as a sort of occupational disease or exposure. Classically, patients have pain at the elbow. They'll have numbness and tingling more towards the inside of the hand in the ulnar distribution. They might complain that when their elbow is flexed, it will cause pain and tingling. For example, if they're trying to use their phone. You want to be wary with this diagnosis that you don't focus on the elbow, and in fact they could have something more proximal, for example, thoracic outlet syndrome, which we discussed in another module. And sometimes the patient can actually have both. They can have, after trauma, TOS, thoracic outlet syndrome, and then sort of a double crush where they also have some symptoms at the elbow, recognizing that the TOS is much more common than what we see at the elbow. The diagnosis is often clinched with nerve studies, but a good history and exam is helpful. Again, we would do things like a good neck exam, looking at range of motion of the neck and Sperling sign. But if they have mostly localized elbow symptoms, we tend to not find much up here. Still, we should do it. It just takes a few minutes. Do a shoulder screening exam. Okay. And then we would move to the elbow. Oftentimes, there's tenderness at the cubital tunnel between the medial epicondyle and the olecranon. It's hard to really point that out, but it's sort of in this area. There's the medial epicondyle, there's the olecranon, and there's the tunnel. You can actually sometimes even palpate the ulnar nerve there. It's often tender there, especially compared to the other side. Occasionally patients will sublux. They'll actually have a movement of the ulnar nerve above the medial epicondyle, but they may not be symptomatic with all patients. Typically they'll have an abnormal Tunnel sign. So this is a tapping of the elbow, and they don't just get their funny bone kind of feeling, but they actually get an uncomfortable reproduction of their symptoms. Neurologic exam again should be complete. We start at the shoulders, we move through the elbow, but the only muscles that will really be weak with ulnar neuropathy at the elbow or cubital tunnel syndrome are the ulnar innervated muscles, the interossei. Say on that side they're weak and here they're strong. Sometimes you need to confirm, so you might do abductor digiti minimi, which is one of the interossei, but I often pit mine right against the patient's. It's sort of a tug of war, and that will often be subtly weak. Of key note here is that abductor pollicis brevis, the muscle that's also a hand intrinsic muscle but innervated by the median nerve, is intact. So this is abductor, or abducting the thumb away from the palm of the hand, pollicis, fancy word for thumb, and brevis because the muscle belly is in the hand. It's an intrinsic muscle. This is median innervated, and this will be strong. Okay, if they're both weak, abductor pollicis brevis and the interossei, both median and ulnar, I start thinking of more proximal things such as thoracic outlet syndrome or two injured nerves. That for carpal tunnel syndrome for the median nerve and cubital tunnel syndrome for the ulnar nerve. Sometimes that happens, say, with older construction workers. Treatment is difficult. Sometimes you give the patient an elbow extension splint at night. Generally, it's poorly tolerated because you can't even scratch your nose. Sometimes there's some physical therapy and myofascial release techniques. In our clinic, we sometimes do hydrodissection with ultrasound, where we try to free the nerve up away from the cubital tunnel. And if all fails and they haven't really improved, and they have abnormal nerve studies, which we also do in our clinic, they might go forward with the surgery. Surgery can either be releasing the ulnar nerve where it is or transposing it, putting it away from where it is and outside the cubital tunnel. The key here really is to try to make an accurate diagnosis and to recognize if the patient's really not improving, they may need more specialized treatment.